Today, we delve into a critical medical case study, diagnosing hyponatremia and polyuria in a subarachnoid hemorrhage patient. Hyponatremia, defined as a serum sodium level below 135 milliequivalent/L, is a common electrolyte abnormality in patients with aneurysmal subarachnoid hemorrhage, occurring in 30% to 56% of cases. It is associated with longer hospital stays, increased morbidity, and a higher risk of vasospasm. Polyuria, the excessive production of urine, typically over 6 liters in 24 hours, often accompanies hyponatremia in these patients. The concurrence of hyponatremia and polyuria in SH patients presents a diagnostic challenge, requiring differentiation between syndrome of inappropriate antidiuretic hormone secretion, or SADH, and cerebral salt wasting, CSW. Let's consider a case. A 42-year-old man is admitted with a subarachnoid hemorrhage from a ruptured anterior communicating artery aneurysm. He's stabilized in the ICU, intubated briefly, and an external ventricular drain, or EVD, is placed to manage hydrocephalus. For the first few days, things look stable. But on day 4, the nurse calls, "Doctor, the sodium dropped again. Now it's 125. And his urine output has shot up to 3 liters today." Your eyes narrow. Hyponatremia and polyuria in a neurosurgical patient. You start mentally scrolling through the differential. Let's examine the usual suspects. Syndrome of inappropriate antidiuretic hormone secretion, SIAD, is common after CNS insult due to excessive ADH release. The patient is euvolemic or slightly hypervolemic with concentrated urine. Cerebral salt wasting, CSW, is less common but easily confused. It involves volume depletion from renal sodium loss. CSW mimics SIAD biochemically, making differentiation challenging. Adrenal insufficiency, a cortisol deficiency, can also lead to inappropriate ADH retention. Iatrogenic factors, such as hypotonic 4 fluids, mannitol, or diuretics, can also contribute to hyponatremia. The intern says it must be SADH. That's what we always see in brain injury. You smile slightly. Maybe, but let's check the clues. At first glance, hypotonic hyponatremia with concentrated urine points to SIADH. But then you notice, the patient has polyuria. He's losing weight and his CVP is low. His mucous membranes look dry. You think SIAD shouldn't cause volume loss. So you decide to try a saline challenge, 1 liter of isotonic saline. If this were SADH, the sodium should not improve and urine would remain concentrated. If it's CSW, the sodium should rise, the kidneys crave the replacement. A few hours later, the repeat labs come back. Serum Na from 125 to 128. Urine output brisk, 1.2 liters in 3 hours. Your heart leaps. Brisk diuresis with saline favors cerebral salt wasting. But you double check, maybe it's just dilutional correction? Then you review the fractional excretions. The pattern fits perfectly, CSW. So what's happening? In cerebral salt wasting, brain injury triggers natriuretic peptides, especially BNP and ANP. These cause renal sodium loss, volume depletion, and secondary ADH activation, worsening hyponatremia. The paradox: the labs look identical to SADH, low serum osmolality, high urine osmolality, high urine sodium. But the volume status and response to saline tell the true story. In contrast, SIAD equals ADH excess, leading to water retention, euvolemia, or mild hypervolemia. CSW equals salt loss, leading to hypovolemia and a secondary ADH response. Treatment differs dramatically. For SADH, it's fluid restriction, salt tabs, sometimes vasopressin antagonists. For CSW, it's the opposite, salt and volume replacement, sometimes fludrocortisone. You order isotonic saline, start fludrocortisone 0.1 milligrams bid, and monitor not every 4 hours. Over the next 48 hours, sodium stabilizes at 135, urine output normalizes, and the patient's hemodynamics improve. Now, for the take-home lessons. Don't assume all post-SAH hyponatremia is SIDH. Assess volume status carefully. Look for polyuria and negative fluid balance. The saline test is a quick bedside differentiator. No rise in Na indicates SIDH. Brisk diuresis and a Na rise points to CSW. Fe uric acid and phosphates stay elevated in CSW even after sodium correction. CSW is salt wasting, not water excess. Treat with volume and sodium repletion, not restriction. You conclude your talk with a smile. Sometimes, the salt is not wasted on your fries. It's wasted by your brain. When in doubt, give a liter and watch what happens.